So we will have an extended panel discussion. Before we will continue with the second talk of Vikas Mittal. Vikas is situated in Limbal in India, and he has really a vast experience with limbal stem cell deficiency situation, which we don't know in Europe, these huge numbers of patients. And we're so happy that you share your results with us here in Europe. And for all the others, we will continue discussion in English. And those who want to participate to the simultaneous transduction, you can click on the globe symbol on the symbol line down and go to German or English, I'm not sure. And there you will have the German transduction, because from now on we will start the discussion in English. Vikas, we are very happy to see you here, and you can start.
Yeah. Thank you so much, Professor Sherman, and it is really a fantastic webinar going on. I saw that live surgery also. Congratulations to you and whole of your team, and thank you so much for this kind invitation. So I'll go ahead. I bring greetings from this northern part of India where I practice, place called Limbal. And the topic given to me is SLET. This is a technique of limbal stem cell transplant called simple limbal epithelial cell transplant. So what I'm going to do is I'm going to share my learnings during my SLET journey. The first SLET we did 14 years back. And as I'm primarily a clinician, so I'm going to put forward a clinician perspective. For the ease of presentation, I've divided this talk into these 6 parts and given them some fancy names. So let's start. The first story is dream. So I did my cornea fellowship close to 2 decades back from LV Prasad Eye Institute, home to largest clinical data set on limbal stem transplant patients. And at that time, I used to see a lot of follow-up patients of SLET done by Dr. Virender Singh Sangwan, my mentor. I personally performed a lot of SLET surgeries as well. After finishing my fellowship, I came back to my place to start my practice and started doing whatever I had learned in my fellowship. The thing which I was not doing but dreaming was of SLET. I wanted to make a difference in patients who were coming with limbal stem cell deficiency secondary to burns, but you know it was difficult, and I was dreaming that can I do it in Ambala, a small place as well. This desire became stronger when I saw this boy who came very early in my practice. He had a lime burn, and while I was managing the acute phase, I knew that he'll have to travel to Hyderabad for stem cell transplant. And I tried to convince him that you have to go, but because of socioeconomic status, the family it was very challenging for them to travel 1,000 miles away. I started thinking of developing a stem cell lab in my place. I collaborated with a biotechnology department nearby and got a genetist, a scientist also, requested him to get trained from LV Prasad Eye Institute and tried to solve all those nitty-gritties. And what I found was, you know, working in a stem cell lab is far easier than creating a stem cell lab. It needs a lot of regulations and it is exorbitantly expensive. So I tried to convince this family again that you might have to go and I'll have to do something. But parents told me, I still remember, they said, doctor, at least one eye is saved so he can carry on his life with one eye, but we can't travel. During the same time, I happened to travel to Hyderabad and I was talking to Dr. Sangwan in one of the meetings and I was telling him that this is the problem I'm facing. And he said that he's doing some different technique where the cultivation of these cells can be done in situ in the patient eye itself. He was, you know, giving me cunningly a metaphor of test tube baby versus in situ pregnancy. And he told me how he is doing that particular technique. So I came back and did that surgery in this patient. Took the limbal biopsy from a healthy eye, similarly that we used to take for SLET, and then these spaces I chopped and placed it over the limbus. And when I saw the follow-up, I was surprised that, you know, cornea was coming back alive. So this corneal, the conjunctival phenotype was getting converted into corneal phenotype. I was so excited, shared this photograph with Dr. Sangwan. By that time, he had termed this surgery as SLET, simple limbal epithelial cell transplantation, and this landmark article has changed the way we deal with limbal stem cell deficiency patient these days. Till then, so far we have done close to 90 cases of SLET, and that the dream of doing a LSCT actually came true. We have done LSCT for patients who had thermal injuries, alkali injuries, acid injuries, uh, uh, and the learning curve. The learning curve is not, it's very minimal for a trained cornea surgeon. So I learned it just from a discussion from my mentor. And recently we had done a course from Cornea Society of India, and we found that 80% of trainees, they could actually do it within 6 months of time. In fact, this photograph is surgery done by my fellow during her first year of practice, and you can see it's not that difficult. And this has been published by Basu also, that if the surgery is done by an experienced surgeon or a new surgeon, results remain same. So since I built it up, let's see how this surgery is actually done. So I'll show you a short video. What basically we are interested in this pigmented area, the palisades. We have to take this biopsy, limbal biopsy, close to just 2 to 3 millimeters. So I'm starting the section from the conjunctival side. We need a conjunctival handle. This is tenon-free conjunctiva. Once you reach limbus, I'm using 15 number blade, blunt size, and carefully dissecting till the end point is till you go at least 1 millimeter into the clear cornea. So once this dissection is done, this conjunctival part, which is which is basically the handle, that is cut, and then this is the biopsy that we are really interested in. Here, while cutting, I'm using Vanna scissor, staying flat to ensure that I don't disturb any of these cells. Then the patient's diseased eye is draped, 360-degree peritomy is done. This is, and then once the peritomy is done, all the adhesions are cleared. Ensure that the globe can move freely. Once the periphery adhesion are cleared, then you start finding this plane of pannus where the conjunctiva has actually grown over it. And this, if you have done a AMG in the acute setting, it is very easy to peel off this pannus. So this denuded area is covered by a wet amniotic membrane and secured with fibrin glue. And this is a very important step, because this is the basement membrane over which these cells are going to get cultivated and crawl. So ensure that the amniotic membrane is very well in place. Now this limbal biopsy piece is chopped into multiple pieces, generally 10 to 16, arranged in 2 circular rows. Periphery and in the mid periphery, center should remain, we should not place any explant there, and it's secured with again fibrin glue. Once you have placed a fibrin glue, wait for at least 5 to 10 minutes. Ensure that all these transplants can be is stable, and then cover with the bandage contact lens, and the surgery is over. Let's see the results. We were a part of multi-center trial done at 7 different centers, and what we found that success rate of SLET was close to 80%. And this success rate has been found in various other studies also. This is the largest study on SLET, again, 80% success rate. SLET done for failed CLET, again, 80%. This is a review of 31 studies, more than 80% success rate. In a way, the success rate of SLET is comparable to CLET, and at a cost 1/10 of the cost of CLET. Maybe this is the reason that this is a single stage surgery, inexpensive and minimum learning curves, that this has been surgeons around the globe are practicing SLET these days. There has been a few modification also, like 2 amniotic membrane instead of 1, or people place explants and over it cover with the amniotic membrane. We recently have done SLET without amniotic membrane, and this is a Russian article where they have used even without glue, they have performed SLET. So it has been changing the way we deal with limbal stem cell deficiency cases. Let's go to our second story. So how do you follow up SLET? We give steroids for 3-4 months and ensure that bandage contact lens stays for at least 6 to 8 weeks. By that time, the epithelial cells, they get really mature. In one of my patients, on I think 3rd or 4th day, I saw that the BCL was fallen off. At that time, I thought maybe we can stain and see how it's looked like. And when we put a fluorescent stain, it's a beautiful pattern that I saw. The cells were coming from individual explant, and it was merging with the epithelium from another explant, and it was how it's creating this epithelial sheet on the surface. We did a study. What we did was daily or alternate days. Serially, we imaged 5 or 6 patients, and we found that was a similar to what we used to see in SLET or stem cell lab. There also we used to use a monolayer, and here similarly the whole surface was getting epithelialized from epithelium from individual explant, and it takes generally 2 weeks for whole cornea to get nicely epithelialized. As a clinician, I know that this transparent looking epithelium is of corneal phenotype, but researchers have also proved it using impression cytology, confocal, PK after SLET buttons, that this epithelium that comes is of corneal phenotype only. Let's go to story number 3. So this story belongs to a very old man who had this large OSSN or conjunctival limbal tumor. So when I was talking to my oncology friend, he said that we'll have to do at least 3 millimeter excision, extended excision, and once this is done, whole limbus will be knocked out. So be prepared to do a stem cell transplant later. So at that time, we thought, how about doing the stem cell transplant right now or concomitant? So we did in one sitting, removed this tumor and did a SLET as well. And we found that even after 7 years of follow-up, there was no limbal stem cell deficiency and no recurrence of tumor as well. Same has been seen and performed by other surgeons as well. Another application of SLET has been found was in pterygium. People have done mini SLET, and this randomized control trial showed that the SLET done for pterygium may have equal outcome as we get with routinely done CAG for pterygium cases. Very important application has come up is use of cadaveric allo SLET in acute chemical burns. Here, if you use that, the epithelialization time really reduces, and chances that you'll have a better prognosis for SLET later increases remarkably. We learned about collateral damage while we were dealing with pediatric eyes. We know that pediatric eyes are different from adult eyes, and we also know that pediatric SLET results are not that much encouraging. We keep seeing every now and then pediatric chemical injuries by various different chemicals, and we had published the first pediatric SLET series in which these kids were managed from acute phase till the last visual rehabilitation. During the acute phase, these 4 eyes that included in the study were grade 6 DUA classification burns, and time for epithelialization was 1.4 to 4 months. And this is what we were left with once the acute phase was over. Total limbal stem cell deficiency, extensive symblepharon, and obliteration of fornices. And now at this time, they underwent SLET, and you can see this beautiful, nice corneal phenotype. And in one patient, we did a transplant as well. So the duration when we do SLET after the injury is very crucial. In pediatric eyes, generally we tend to do it a bit early, but it is important that the inflammation is settled. So it took at least 4 to 6 months from the acute phase. And you can see the success was achieved in all the cases. And you can see the even visual improvement. But this success was after 2 surgeries. After one surgery, there was partial success in 3 cases, and 1 patient had a full success. What do you mean by partial success? There was a recurrence of symblepharon in quadrant which was not touching the center of the cornea. So here we learned was that damage of conjunctiva is also important. So we were taking care of limbus, but we were not taking care of conjunctiva. In these cases were managed by doing a repeat mini SLET, along with that a conjunctival autograft, and this has changed the way. They never had a recurrence of a symblepharon again. So which means that you'll have to deal with the conjunctival damage as well. With this understanding, when we see the patients now who has symblepharon as well, what we do is do a CAG in primary sitting only, which means we do CAG plus SLET, and generally the results are very encouraging. Second last story is this person who had an alkali burn, and we had done a SLET. After SLET, his vision was 20/100, and this was because of the anterior stromal scar. So this was very early, I think my 7th or 8th case. So at that time, we thought that maybe we should do something for visual rehabilitation. So what we did was femtosecond assisted anterior lamellar keratoplasty, and vision improved to 20/40. Very happy. So is it that all these scars post SLET needs FALK or DLK? Well, have a look at another patient who had undergone SLET. You can see the scar, And once you see this scar along, the epithelium is becoming better, even the scar is getting fainted off with time. And what we learned was these scars, they tend to faint off, and generally after 1 year or 2 years, if you use a contact lenses, clear lenses, the vision is pretty acceptable. Why this happens? Maybe because of the mesenchymal stem cells that we are giving along with those pieces. Dr. Sunil Chauhan has a lot of work in that. So but we see fainting of these scars with time. In case you have a really bad scar, full thickness scar, you have to do a penetrating keratoplasty. So this boy had a line intrastromally. So after SLET, we did a penetrating keratoplasty, did well. Another scar, not improving with contact lens, and did a keratoplasty. So these keratoplasties done after SLET are successful because now you have taken care of the ocular surface, and this has been seen in other studies as well. Maybe maybe after you have plated these cells, they actually reach at the limbus, and that is the original niche. We saw this pigmentation in all our keratoplasty patients. So maybe it's from there this epithelium is coming, and we are not seeing any limbal stem cell deficiency. So the last story is of this young boy, 18 years old, about to go in university, and his left eye has a vision of 618, and with contact lenses improving to I think 612. And why I'm showing you this boy is because the same boy who had undergone SLET 14 years back, when the parents thought that maybe he'll have to carry on the life with one eye only. It's been very satisfying. 14 years on, and there is no recurrence of stem cell deficiency. You can see the cornea is maintaining well even after 14 years. And we have close to 12 patients who has more than 10 years follow-up, and who has maintained the surface, and there is no recurrence, which means that maybe SLET is going to last long. So any stem cell transplant that you do, even on a long-term basis, the results are very encouraging. So this was all about my journey into SLET so far, and it has been very encouraging and very satisfying. My gratitude to my mentor, Dr. Sangwan, and all my fellows, colleagues here in LGI Institute. Thank you once again, the whole team, for giving this kind of opportunity and letting me share my thoughts with you. Thank you so much.
Yes, because thank you very much. It was a remarkable talk and a very interesting alternative technique.